right, so I'm doing the PEM CCM conference talk today. We have this 13-month-old seizure. This one?
Yeah, that one or this one.
Oh, okay. Hi, my name is Vicky. If you guys don't know me by now, not Rosie. Thank you, Dr. Malino, Dr. Khan, and Dr. Liang for helping me prepare for this conference. So let's start with the pre-hospital history. So we have this 13-month-old infant that was brought in by mom on foot. So I was told that the mom came running into the ER holding the seizing child. Mom woke up, said that she noticed that the child was foaming at the mouth. Eyes rolled back, came into the ED immediately. She lived close apparently because she ran in. She had not given any interventions at home. And the child, so in the initial assessment, so we're doing the ABCs first. So the airway, the child was foaming at the mouth, but was protecting her airway when I spoke to the team about her. Breath sounds were heard bilaterally, but they were transmitted from upper airway. And cardiac, she was tachycardic and unresponsive because she was seizing. In terms of the triage vitals, there wasn't any initial blood pressure listed. I'm not sure why. The heart rate was in the 170s, respiratory rate 41, sitting at 98% on room air though. The temp was 99.9, so not necessarily febrile, but up there. Finger stick was 81. So the preliminary problem list. So this is essentially status. We'll talk about the definition of status later, but the woke up seizing, came in seizing, obviously more than 5 minutes. So she was also like tachycardic, tachypnic, altered. At this point, we don't know if there is a seizure disorder, but she is protecting her airway, but we have to keep a close eye on that. And then, is there an infectious etiology involved? So the initial intervention, so an IV was established, O2 was placed on non-rebreather, suction, cardiac monitor, and the initial intervention was Ativan. I was told she kept seizing, so they gave a second dose of Ativan. And then they ordered for Keppra, but Keppra was delayed. And they also ordered for phosphonatoin just in case the Keppra didn't work to have on the side. And so because of the delay, they ended up giving the third Ativan. And then she stopped seizing after she was loaded with Keppra, actually. But then the phosphony was, there's a miscommunication and was given and wasn't supposed to be given, but it didn't hurt the patient. In terms of the HPI, so this patient actually does have a seizure disorder. The seizure was witnessed by mom as generalized tonic-clonic. The seizure was going on for an unknown duration prior to coming to the ER. It looks like in the chart that she may have been seizing 20 to 30 minutes once she came into the ER. Mom said there was no missed doses of Keppra, and there were no meds given prior to the hospital arrival. In terms of ROS, mom says that baby went to sleep at baseline the night before. No infectious signs, no fevers, no diarrhea or anything of that. Past medical history, so this child does have a history of hypoxic ischemic encephalopathy. Epilepsy is on Keppra and global developmental delay. In terms of the birth history, so the mom was a 29-year-old female, G2P1010. She actually came in a few days prior to the birth, and she was advised to have an induction because she had a category 2 tracing. But she refused, left the hospital AMA, came back a few days later, and had an emergency section, category 3 tracing, and then X39 weaker. They noted to have thick meconium-stained amniotic fluid, and the child was subsequently intubated at 4 minutes of life. And in terms of the neurohistory, so at 3.5 hours after birth, the child had a seizure and then was loaded with phenobarbital. And then because they were concerned for HIE, they transferred to Bellevue for a cooling protocol. And a cooling protocol is when they lower the body's temperature to slow the metabolic rate, to to help the cells, to help the neurons recover from any like neurological damage, to prevent any neurological damage. And so she was transferred to Bellevue. She had persistent seizures while she was there. She was loaded, or she was given phenobarbital, like redosed with phenobarbital multiple times. They added phenytoin. They eventually put her on a Versed drip. In terms of her labs, she had a negative LP. She became hypotensive at some point. They started her on a dopamine drip. She had a positive trope at some point as well. They thought she was septic and they gave her antibiotics. About a month after she had been there, they ended up sending her home on Keppra and phenobarbital. In terms of imaging, they did do an MRI. It just shows HIE versus a seizure focus. And they did EEGs that showed evidence of seizures. More of the neurohistory. So the child's last seizure was 3 months prior, and she also came to Kings County at that time too, but she wasn't in status at that point. She is being followed at Bellevue Neuro for any of her neuro stuff. So she had last had a televisit with Bellevue about 2 months prior, and they adjusted her Keppra dosing, and she's only on Keppra. So in terms of her meds, she's on Keppra, 200 milligrams BID. She also has diazepam, PRN, when she does have breakthrough seizures. She's up to date on all of her vaccines, and she has no known drug allergies. In terms of her exam, she was actively seizing when she came in. She had this hypertonic shaking of the bilateral upper and lower extremities. She was unresponsive, foaming at the mouth, eye deviation, sinus tachypneic. Any questions about the HPI, the exam? No? Okay. So in terms of differential diagnosis, so she was in status. If we hadn't known any history, is this like a first-time seizure? Is this provoked? Is this unprovoked? If she has a seizure disorder, what meds is she on? Has there been any changes? Was there an inciting event? Was there any sort of change from baseline, essentially? So the ED course, just to go over, she got 3 Ativan times 3. She was loaded with Keppra and also phosphenytoin. Labs are sent. Peds Neuro was called, and PICU was also consulted. In terms of her labs, nothing too significant. So COVID was negative. The only thing was the phosphate was a little elevated, and she was a little acidotic. So things I'm going to talk about is seizures, first-time seizures, status epilepticus, treatment, neonate versus infants and older children in terms of treatment. So the definition of seizures is it's a clinical expression of abnormal, excessive, or synchronous discharges of neurons residing in the cerebral cortex primarily. You get this abnormal paroxysmal activity that's intermittent and usually self-limited, will self-resolve in like seconds to minutes. And the pathophysiology behind it is essentially you get this overexcitation or under inhibition of these neurotransmitters. And it can ultimately lead to neuronal loss. And the more episodes that you have, and the more prolonged it is, the more significant impairment that you can have. And in terms of seizures, like in a broad category, you have provoked versus unprovoked, and then you have status epilepticus. Provoked meaning like if you have like metabolic derangements, fevers, TBI, intracranial hemorrhage, anoxia, toxins, things like that. Unprovoked is like a structural persistent brain pathology. So like, for instance, our child had HIE. This falls into the category of unprovoked seizures. Can also be metabolic disorders, autoimmune disorders, remote infections, or genetic disorders as well. So seizures in peds, the reason why it's so important in peds is because 1% of all pediatric ED visits are seizing patients, and the highest incidence is less than 1 year olds. And the theory behind that is that the excitatory pathways develop before the inhibitory pathways. And so they think that kids have a tendency to have seizures because of that. The other thing is that 10% of adults and 20% of children with epilepsy will have one or more episodes of status epilepticus, so it's important that we know how to treat it. And also whether or not we should be sending workup for it or having them stay in the hospital. So in terms of neonatal seizures, it's usually in the first week of life, and neonatal meaning like the first 4 weeks of life. So for neonatal seizures, these are the 4 types. You get the subtle, the clonic, the tonic, and the myoclonic. For subtle, it's just like, it's subtle. It's like random eye movements, it's eye blinking. You can get sucking, smacking, tongue protrusion. You can also get bicycling or pedaling of the legs, and you can also get long pauses like apnea. For clonic seizures, it's more like rhythmic jerking of the face, the tongue, the arms, the legs, or regions of the body. For tonic seizures, it's more so like stiffening and the tightness of the muscles. You can get turning of the head or the eyes, bending or stretching of the arms or legs. And then myoclonic seizures are more like quick, single jerking motions involving one arm or leg or the whole body. Are there video? Oh, okay. Here's a video of a neonatal seizure. So the one on the left is something that babies normally do, just like a jitteriness. And you see the physician holding the arm and it stops. Versus a seizure where you try to restrict the arm, you'll still see this twitching. Okay, and then seizure categories for infants and children. You get the classic, the focal, which is unilateral. They don't lose consciousness. And then you get the complex seizures where they lose consciousness, but it's still unilateral. And then you get the generalized convulsive seizures, which is like what you usually think of when you think of seizures, like the bilateral shaking. It can happen with or without loss of consciousness. And then you have absence seizures in children, where they just have this like sort of staring spell, and they have this altered awareness. And with all of these types of seizures, you can have status as well. The other thing to consider is seizures versus seizure mimics. You can have syncope, where you have loss of consciousness, and you can have this twitching, but the key important thing is you have this rapid recovery. You also can have breath holding spells in kids, where it usually occurs in 6 months to 6 years of age, and it's usually triggered by something emotional. They get upset, they have decreased cerebral blood flow, and they pass out, and that's what this breath holding spell is. And the other thing is it's also like they have a quick recovery. Psychogenic non-epileptic seizures is also another form of seizure mimic. You have to get a good history from the parents about this. They can have this side-to-side movement of the head, of the legs, or the arms, and the eyes are closed, but they are distractible, and they can, a bicycling movement is very specific for this type of mimic, and they're also emotionally triggered. So this was a talk that someone gave last year about syncope versus seizure, and they showed this video. Tell me if you guys think that this is a seizure or a syncopal episode. You can see. What do you guys think? Yeah, syncope. But you can imagine that if someone brings their family member in saying that they witnessed these sort of behaviors, that they can assume or think that it could be a seizure. Again, like the most important history is that how long did it take for them to come back to baseline? This is just an infamous quote in our lounge regarding this video, if people didn't have context of why it's in our lounge. And this is an example of a seizure in a child. So you can get, with seizures, you can get this lateralized tongue biting, which is highly specific for seizures. You can get flickering of the eyelids, deviated gaze, dilated pupils with a blank stare, lip smacking, increased heart rate and blood pressure, desaturations on the pulse ox during the event as well. Okay, so the workup for unprovoked seizures, there was a study that was done that looked at the practicing parameters, evaluating for first-time non-febrile seizures in children, and basically looking at the evidence behind whether or not we should be ordering labs, imaging, EEGs from the ED standpoint. So they reviewed the evidence and made recommendations based on this three-tiered classification, one having the most evidence and So in terms of labs, they said children who are greater than 6 months, there's really like insufficient evidence whether or not you should be sending labs. Unless there's like some sort of history showing that there's an electrolyte imbalance, for instance, like the family's telling you that they were vomiting, they've had diarrhea, they haven't been eating, then it's not really of any value. For kids who are less than 6 months, they do say to send labs because there is a risk of hyponatremia, especially in the setting where if the parents are diluting their formula, they can get this hyponatremic, and then have seizures. In the studies that they looked at, there wasn't enough power. There were only 2 reports of positive tox screens. And again, just like if you can get that history from the family, if they're at risk of having this sort of drug exposure, or if the family has someone there who has like substance abuse, things like that. In terms of LP, again, there wasn't enough evidence. They said that there's limited value in LPing a child who has unprovoked seizures, unless you're thinking that there's a possibility of meningitis or encephalitis. And again, that be through history, fevers, things like that. For EEG, this is the only thing that they found that had enough evidence that you should get, but the only thing that they couldn't comment on is the timing. So does this have to happen as an inpatient? Does it have to happen within 24 hours, or can it happen as an outpatient? EEGs can determine the seizure type, the seizure syndrome, the prognosis, it can give them an idea of how to treat. So it is useful, but they weren't able to comment on whether or not it has to happen right away or if it can happen outpatient. In terms of imaging, they did find that 1/3 of the children with first-time seizures had abnormal imaging, but most did not influence the management. So let me see. There was a study done in 2015 where they looked at imaging done on 28-day-olds to 18 years, and they looked at scans from the ED versus scans within the first 4 months of the child visiting the ED. They enrolled 475 patients out of 625, and they found that 40 had intracranial abnormalities, which was 11%, but only 3 really had emergent or urgent abnormalities. That included like tumors or metastasis or infarction that required some sort of intervention. And the most important thing was that they were able to get some sort of history in order to get this imaging. For instance, like if it was a focal seizure, if there was any neurological deficit. So these patients that did have something ended up falling into more like high risk past medical history. And so again, like getting a good history will help guide you whether or not you should get this imaging.
Did it comment on whether they had an abnormal neurologic exam?
Yes, yeah.
Okay.
Yeah, so they said abnormal neurological exam or abnormal history, focal seizures versus like just like a general seizure. So in summary, they recommended EEG, but again, the timing, they couldn't comment really on the timing. LP labs imaging is case by case, and you should take into consideration the age of the child. So in terms of status epilepticus, so the definition used to be a single epileptic seizure that was lasting more than 30 minutes or a series without returning back to baseline in a 30-minute period. But obviously, we're not going to stand there and watch a kid seize for 30 minutes before we do something. So the new definition is that it's a seizing child for more than 5 minutes. And the reason being is that if someone's seizing for more than 30 minutes, they're at risk of neuronal death, injury, or alterations. And so if you look at this chart, you have in the first 30 minutes, you have this compensatory phase where you have an increased catecholamine surge, increased cardiac output, cerebral blood flow, glucose in the brain. And this is the reason why you should put children on oxygen, even though they're sighting well during a seizure, because they do need that extra oxygen support if they do go into this decompensatory phase. So again, if they're seizing past this 30 minutes, everything starts to go downhill. The other thing to keep in mind is that when you're seizing for a long time, the GABA receptors also change and they're less effective. They're less, what's it called? They're less sensitive to the GABA, to innate GABA, and therefore less sensitive to the benzos that you're giving. So you always want to give benzos as early as possible for it to be the most effective. Complications of status epilepticus are sudden death, acidemia, all these bad things. It also interferes with any sort of intervention that you want to do, like if you want to get a CT, if you want to try to fully evaluate them in terms of trauma, if you want to get an LP, things like that. So in terms of treatment, this is a pathway given by CHOP. I know it's a busy slide. So just to break it down, and in terms of initial management, you always want to assess the ABCs, get your IV, get your O2, cardiac monitor, have your suction there because you want to make sure that they're protecting their airway and that you can suction any sort of vomit or secretions that they have. Check their glucose because that's easily reversible. And then if you can, get just a brief history from the parents or EMS. And so first line therapy, the first 5 minutes, you always want to give benzos, 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 just like I said earlier. Yeah. And like I said, the longer you wait, the less effective it is. The types of benzos that you can use, Ativan, diazepam, Versed, all can be given IV, IO, or IM. Per rectum, if you can't get an IV, you can give diazepam. You can also give a buccal dose of Versed, which I just learned. Yeah. Yes, you can also give intranasal. For the second line therapies, this is where the controversy is. There's a lot of controversy in giving fosphenytoin, Keppra, phenobarb, and there's a lot of papers written about it. So Fosphenytoin is typically given in the US. Phenytoin is given in the UK. And the reason being is that there's a smaller side effect profile for fosphenytoin, and you can also give it at a faster rate. So that's why the US has switched to phospheny. The dosing, the mechanism of action for phospheny is it blocks sodium channels, and it can slow the recovery and therefore limit repetitive firing. Keppra it binds to the SVP2A receptor, and it blocks calcium channel and sodium channel and currents that modulate the GABA receptors. Barbiturates bind to GABA receptors. Barbiturates can work better in neonates than they do in children. These are the major studies that they did in terms of comparing phenytoin and Keppra. So the concept and the Eclipse were the two major ones done in 2019. The concept was done in Australia and New Zealand. They looked at 3-month-old to 16-year-olds, comparing the two, and then also the Eclipse was done in the UK, where they looked at 6-month-old to 18-year-olds. They found no difference, really. Like Keppra was not superior, essentially. And if the second line didn't work, they would add, so if you were given phenytoin in the study and that didn't work, they would add Keppra on top of it. If you were given Keppra and that didn't work, they would give you phenytoin and see it as third line. The other thing I want to point out is that it takes 20 minutes to infuse phenytoin versus Keppra, it takes 5 minutes. But they did see no difference in terms of which one was, if Keppra was superior. Another major study was the ESET study. It was done in 2-year-olds and above. It was a randomized trial where they compared Keppra, fosphenytoin, and valproate. And here they also found no difference. In terms of neonatal status seizures, there is a study called the NeoLeave-2 trial where they looked at 83 neonates and compared Keppra versus phenobarb. Because Keppra was getting popular at the time for older children and it was very effective, they wanted to see if it worked in neonates. They did continuous EEG monitoring, but they found that phenobarb was actually just more effective, 80% versus 28%, and absolute risk reduction was 52%. If you're thinking of third-line therapy, you should already be thinking about refractory status epilepticus, and you should already be considering coma induction, so starting a Versed drip or a phenobarbital drip. You can also do a propofol drip, but there's a risk of propofol infusion syndrome, which is like hypotension, cardiac failure, rhabdo, metabolic acidosis, kidney failure, which can be fatal, and then ketamine as well. If you're going to intubate and pursue RSI with these patients, I know there's a concern for rhabdo, so people think to avoid SUX, but rhabdo actually comes later on, and SUX is shorter acting, so if you're concerned about monitoring seizures, you want to give SUX versus ROC. And so things to consider when you're choosing medications is the side effect profiles. What are they taking as their home meds? If they have like a psych disorder. And the reason being is this is a busy slide, but I want you to focus on this part. Phenytoin and fosphenytoin, again, like I said, like fosphenytoin can be given in saline and dextrose, and it can be given faster than phenytoin, and there's less of a toxicity risk. The reason why you want to know if there's a psych disorder is if you're giving Keppra, it can cause aggression, so you might want to avoid that. The other thing is if the child is on phenytoin at home, the toxicity level will be, it's better to give Keppra because you don't want to cause any side effects by giving too much phenytoin. And then phenobarb, you can have hypotension and respiratory depression, things like that. And so going back to our 13-month-old, what happened to this child? This child was eventually admitted to the PICU. They initially thought maybe she had suboptimal Keppra dosing because she had gained weight from 2 months ago. She was initially on 52 milligrams per kilogram per day, and she gained about 0.6 kilograms. So they thought that maybe she was being underdosed at that point. She was put on seizure precautions. Her Keppra dose was increased to 300 milligrams BID, and then Ativan PRN and Diastat PRN, and then follow-up Neurorex. Neuro just recommended to increase her Keppra dosing and to give her Ativan as needed. And she ended up being transferred to the peds floor the next day. She had an episode of hypoxia, but it self-resolved. She didn't have any seizures since she was admitted. She was drinking formula. She did spike a fever, and she had viral exanthem, and she had a CRP of 6. UA was negative. Blood cultures were also negative, and ProCalc was negative as well. She was discharged on the second day. She was fever-free after 24 hours. She had no further seizures. Her Keppra was increased. She was back to her baseline, and then she's going to follow up with Bellevue. So take-home points for status epilepticus is consider the age, consider the side effect profiles of the medications that you're giving, get a good history from the parents, a good physical exam, give benzos early, phenobarb for neonates, and then Keppra has a pretty good safety profile. References, thank you, Dr. Leong, Dr. Khan, and Dr. Malino. Any questions?
Just a couple of quick comments comparing it to adults. So besides a seizure that doesn't stop for 5 minutes being status, if they have 2 seizures in a row and didn't wake up in between, that counts as status as well, at least in adults. And the other thing is there's some, Valium doesn't work well IM in adults. It's kind of irregularly absorbed. That's why even for DTs, it's not a good drug to use IM. Ativan might work IM. There's some controversy now about it. The one that works the best IM, immediately is Versed of the 3. The other thing is with phosphatone versus phenytoin. We have phosphatone here, like you mentioned. It is much safer. You can go up to a max in an adult to 150 milligrams per kilo if they're really seizing. With Dilantin, you shouldn't go fast than 50 milligrams per kilo. Like you mentioned here, they can get hypotension or arrhythmias because of the propylene glycol, which is the solvent. In fact, with drips of the benzos, particularly with Valium drips, you got to be careful also because those drips use propylene glycol as a solvent when you're giving it as a drip, so they're better as pushes. And the other bad thing about Dilantin versus propylene glycol, in adults at least, is like you have purple glove. I've seen if the Dilantin infiltrates, plain Dilantin, because its pH is so high, it'll cause terrible burns. So if you don't, but phosphatone won't. And in fact, you can get phosphatone IM in adults. So it's a much safer drug. We have it here. And you always should actually get both of them on monitors if you can, and watching the blood with the blood pressure cuff to be careful.
Yeah, I have something I wanted to say. Which is, if you just think about it, like the reason people have seizures is because they have abnormal electrical activity in their brain, right? And for most kids, the reason for that is they have some sort of congenital abnormality that can't be seen on CT, whether it's like an absent corpus callosum or whatever that causes abnormal signaling. That's also why in neonates, you don't have like the classic arm twitching or the leg twitching simply because they haven't myelinated enough to be able to send those electric signals all the way down to their limbs. So that's why in neonates you might only see like the eye twitching or the tongue gesticulation simply because the myelination hasn't occurred yet. But it makes sense then if you're having abnormal electrical activity that's being propagated that you're going to treat with Versed, or you're going to basically treat with like a sedative to kind of quiet the brain down. And so the faster you do it, obviously, the less it prevents further amplification of the abnormal electrical activity. So that's why phosphonate works so great. But the problem is when you give like a Versed and a phosphonate right after, you really have to start thinking about the airway because those patients get really sedated and they stop breathing.
So I remember when you read the chart, you said there was like issues with getting the medications out, or there was a delay or something like that. And the reason is because when we order some weird doses, like a mixed per kid dose, sometimes it'll automatically send the medication to the pharmacy. The way that you actually get around that is when you click the order tab in Epic, there's a Peds frequently ordered section underneath that screen, and then if you click medication from there, it'll automatically go to fixes and choose it. But we'll send an email afterwards, so that, if it's happens in your life, you won't get confused.
Yeah, although phosphonate I think still goes to the infusion center.
Oh, it does? Yeah.
I believe so.
I know for like Kepra.
Kepra does not go.
Yeah, Kepra goes in the fixes.
Right.
Yeah, but like whatever is in that frequently ordered tab should automatically go to the fixes. So that's the way.
I'm pretty sure, I have to ask again, I'm pretty sure that phosphonate nurses can't mix up. I think just something to that effect. So Kepra, you might be able to get.
Yeah, you might be right. Yeah. So then maybe just give Kepra second line, just sure that it's coming down to it.
Or if you're pulling up your second benzo, you call the pharmacy.
Yeah.